2. Let's talk about benign paroxysmal positional vertigo, which has become more common in recent years. The most common symptom is rotatory vertigo that occurs when the head is placed on a pillow, when getting up from bed, or when the head is positioned to the lower right or left while lying in bed. The duration of rotatory vertigo is 30 seconds to 1 minute. The diagnosis is based on direction-changing positional nystagmus during nystagmus testing. The mechanism that causes vertigo is as follows. When old otoliths in the utricle of the inner ear, which detects plane movement, move in mass through the semicircular canal, endolymph fluid flows in the semicircular canal and is detected at a place called the cupula inside the semicircular canal ampulla, which converts the information into electrical signals and sends them to the brain. When a otolith mass is attached to the cupula detects the otolith mass and sends electrical signals to the brain through the nerves, causing nystagmus and making the person feel vertigo. However, this theory is still in the hypothesis stage, although many doctors treat it as if it has already been decided. Based on my observation of nystagmus with Frenzel glasses, infrared CCD camera, head MRI, MRA, head and neck MRA, and cervical spine X-ray in almost all vertigo patients, I believe that benign paroxysmal positional vertigo accounts for about 20% of all vertigo patients. This is a newspaper article about benign paroxysmal positional vertigo, and the title says that exercise, physical therapy is spreading, and drugs are not expected to help. This therapy is a method of returning otoliths to their original utricle through a certain procedure. It is seldom that medications do not work. Even if the standard medicines are not effective, they can be effective enough at the time when the dosage of the medicine is adjusted or the combination is changed. The important thing is to choose the right medicine and the right dosage. Nowadays, exercise, physical therapy for benign paroxysmal positional vertigo is popular all over the world. However, if this approach is taken too far, it can cause unexpected symptoms. Here are 2 typical cases that the exercise, physical therapy was performed excessively and finally persistent dizziness occurred. The first case is a 63-year-old female. As a result of faithfully performing the Epley method as instructed, she began to have a persistent wobbly feeling all the time, even when standing or sitting, except when sleeping, and did not respond to any treatment. The neck MRA of this patient showed that the right vertebral artery was tortuous due to arteriosclerosis, and the left vertebral artery, which was thin at birth, was considerably narrowed due to arteriosclerosis red arrow. This finding indicates that there is poor circulation in the left vertebral artery, so it is not so-called benign paroxysmal positional vertigo, but central paroxysmal positional vertigo originating in the brain rather than the inner ear semicircular canal. Exercise, physical therapy should not be used in such central cases. The other case is a 69-year-old female. In this case, a neurosurgeon pointed out an aneurysm in the right vertebral artery, but with continuous exercise, physical therapy by vertigo specialists at 3 facilities, the unpleasant sensation of wobbly, fluffy dizziness became constant except when she was sleeping. The patient ended up with persistent perceptual postural dizziness (PPPD) and also took medication from a psychotherapist, but there was no improvement. After more than a year and a half of no response to various treatments, she has been taking 2 tablets of cerebral circulation improving drug per day for more than 6 months, and finally there is a sign of effect, but the fluffy feeling continues as usual. In this case, at the time the vertebral artery aneurysm was discovered, benign paroxysmal positional vertigo of otolith origin was denied, and central paroxysmal positional vertigo of brain origin should be diagnosed. In these cases, exercise, physical therapy are not suitable to return the otolith to the utricle. I have had a number of other elderly patients give up on treatment because of these symptoms. One elderly patient performed too much on this exercise, physical therapy, and also developed PPPD. She continues to have uncomfortable dizziness with a wobbly, fluffy feeling and has not responded to any treatment. For this reason, the other day she told me that she was thinking of forming a victims group. Here are some of the other peripheral and inner ear vertigo diseases. 3. Vestibular neuritis. It is said to be caused in part by a virus. Symptoms are severe rotatory vertigo without hearing loss or tinnitus that lasts for more than 24 hours. The characteristic feature of this type of vertigo is that it does not repeat itself. Repeated episodes of rotatory vertigo are often caused by inadequate circulation of vertebrobasilar artery. It is not a so-called transient ischemic attack of the vertebrobasilar artery system, which can easily be mistaken for vestibular neuritis. 4. Vertigo associated with sudden deafness. In this case, rotatory vertigo is a one-time episode and does not repeat. 5. Ramsay-Hunt syndrome. This disease is caused by the herpes zoster virus and causes a rash in the external auditory canal, facial paralysis, tinnitus, vertigo, and hearing loss. 6. It is caused by the mumps virus and results in swelling of the parotid gland, tinnitus, hearing loss, and vertigo. 7. Chronic suppurative otitis media with cholesteatoma. This disease causes the formation of a traffic channel fistula in the lateral semicircular canal of the inner ear due to the dissolution of part of the bone wall, resulting in the appearance of vertigo. 8. Labyrinth syphilis. It is a rare disease nowadays, unlike in the past. 9. Perilymph fistula. External pressure is exerted when a patient suffers a head injury or suddenly dives into the sea, and internal pressure is exerted when a patient suddenly lifts a heavy object or strains in the toilet due to constipation. In such cases, a small hole is made in the thin membrane called the vestibular window or cochlear window, which separates the middle ear from the inner ear, and perilymph fluid flows out through the hole into the middle ear drumroom, causing sudden hearing loss, tinnitus, and dizziness. 10. Delayed endolymphatic hydrops Kami, Nakayama. This disease was first reported in Japan by my master and me in 1978. Patients with juvenile unilateral deafness or unilateral severe sensorineural hearing loss develop vertigo and tinnitus similar to Meniere's disease after several years to several decades. This is not a standard treatment for Meniere's disease, but another one. I will talk about the causes and treatment of Meniere's disease. The well-known endolymphatic hydropsinor ear edema is only a pathological condition, not a cause. There are many theories about the cause of Meniere's disease, such as autonomic neuropathy, allergies, etc., but one of them is the virus theory. In recent years, the world's first theory that Meniere's disease is caused by a herpes zoster virus appeared in Japan. Dr. Shichinohe, a general practitioner of internal medicine in Hokkaido, presented this theory for the first time in the world at the International Society for Virology in 1998. A paper was published in the U.S. that Meniere's disease is a viral neuropathy in 2009. Professor Gottschalk, former chief of otolaryngology at the University of Massachusetts Hospital, reported the following. The temporal bones of 8 patients who had Meniere's disease before death and died of other diseases were removed during pathological autopsies, and the vestibular ganglia were examined using electron microscopy, and viral particles were found in one of them. Some might argue that it's just one case. But the number of patients with Meniere's disease is small, and it is said to be quite difficult to find viral particles. The most common virus that lurks in the nerves is the herpes virus. Therefore, Professor Gottschalk administered a cyclovir product named to patients with Meniere's disease. He reported that vertigo was completely controlled in 32 of 35 patients 91%. However, tinnitus was improved in approximately 50% of patients. Here are the treatments for Meniere's disease in our department. Anti-herpes virus drugs, in order of appearance on the market, are Zavirax, Valtrex, Famvir, and Amenalif, all trade names. They are prescribed according to the patient's preference. Basically, one course of treatment lasts for 2 weeks and then we proceed to the second, third and fourth courses of treatment depending on the symptoms. The duration of therapy is determined according to the patient's manifestations. At present, the vertigo disappearance rate in our department is 88% in 141 161 cases. Here is a specific example of a dramatic disappearance of symptoms. 41 years old, male. He was admitted to the Department of Otorhinolaryngology at a university hospital for a Meniere's disease attack with rotatory vertigo, tinnitus, ear obstruction, feeling of fullness, and hearing loss in the base area. There, he was given steroids and anti-vertigo drugs, but they had no effect at all. Therefore, he had his family bring to the hospital the Famvir that had been prescribed in our department just before his admission and started taking 3 tablets per day. All the symptoms disappeared within the day. Famvir worked dramatically in this case. 41 years old, female. This patient was suffering from Meniere's disease and had recurrent attacks of rotatory vertigo 3 times a week. She was treated with anti-vertigo medicine and steroid pulse therapy at another otorhinolaryngology hospital. There was no improvement at all. In our department, Valtrex was administered at 3 tablets per day for 2 weeks. Her vertigo disappeared completely on the second day after taking Valtrex. However, mild hearing loss impairment remained. The following is a summary of what I have talked about so far. I gave a speech what diseases are associated with peripheral inner ear vertigo, including another treatment for Meniere's disease. I told that in internal medicine, there are many middle-aged and elderly patients, so inevitably there will be more vertigo cases from the brain. Next, I will mention about central vertigo, which is common in middle-aged and elderly patients, and what diseases are associated with this central vertigo.